Okay, today we're going to be talking about meninges and ventricles, so we'll start out with this. And let's start out with general stuff. So kind of getting used to my drawings, I hope, or my template, so that if I had to ask what kind of section is this, first off? Any thoughts? Yeah, frontal section. Okay, so if it were me here, it would be sliced right down the middle. So knowing that this is a frontal section, what's this part of the brain? Anybody? Cerebrum? Yeah, this is the cerebral cortex. Okay, and then coming down, we have basic parts of the brainstem. The top part of the brainstem is midbrain. Good. And this guy, pons and medulla. Here's your spinal cord. Right. And at the very bottom of the spinal cord, you have this thing that's like a hot horse's tail, kind of all the nerves coming out. What is that called? Anybody know? Yeah, good. So this is going to be your cauda equina. Okay, cauda equina, and that's going to be the very tip. Now the bottom of the spinal cord has a special name. It kind of tapers off down here. To this very bottom part. Does anybody know what the name of that is? Okay. The very bottom part of the spinal cord that tapers off is called conus medullaris. Okay, conus medullaris. This means the very bottom of the spinal cord kind of comes down and then tapers, and then the cauda equina comes out of there. What vertebral level is the bottom, is the tip of the conus medullaris at? Do you guys know? Do you remember from vertebral level? That's L2. The very bottom tip of the spinal cord is at L2 vertebral level. It's an L. L2 vertebral level is very bottom of the spinal cord. Okay, that's just the basic orientation. I'm talking about the different meninges. Does anybody know what the meninges are? Have you heard that word before? What are the meninges? You thought? Yeah, they're layers of connective tissue that surround the brain. And then there's one layer of connective tissue, the first layer that we're going to talk about, surrounds the entire area. It's very tightly connected to the central nervous system. Okay, I'm doing this in green. You might want to keep your color. It doesn't matter what color you use, but make sure that you keep your colors consistent because we're going to use this throughout. This is the very first layer, the very first meningeal layer. And it's tightly adherent to the central nervous system. So it goes around all the gyri and into all the sulci and fissures of the brain. Lots of little invaginations, and it's adhered very tightly. And it's the first layer that we're going to talk about today. All the way around. Okay. So this very first layer that is tightly adherent to all the central nervous system is known as pia matter. P-I-A M-A-T-E-R. Okay, take the last word first, matter. Anybody know what the word matter means? I heard it, I think. Mother, yeah, it's mother. So matter means mother. And then pia, what's the word pia mean? Anybody? That's soft. So the very first layer that is connected, very tightly associated with the central nervous system, is a soft mother. Okay, it's pia matter. Okay, first layer on the inside is pia matter. Going on to the very next layer. This one, I'm going to make sure that there's a little bit of space, and there is a little bit of space here with this layer to the pia matter. So again, it's going to go all the way around, but there's definitely a space in between the pia and the next matter.
Is that purple?
I'm using brown. Feel free to use whatever you want as long as it's consistent. Okay. Okay, but the most important thing is that there's definitely some space. Like the pia matter is tightly adhered to the CNS. Well, this is the next layer of meninge that has a little bit of space. Looking all the way through, so it definitely goes all the way through. And the second layer of meninges, does anybody know what it is? Yeah, this is your arachnoid matter. A-R-A-C-H-N-O-I-D matter. Yeah, an arachnoid is spider. So this is the spider mother. You may be asking, why is it called the spider mother? Arachnoid matter has some projections coming out of it all the way to the pia matter, and these projections go all the way around, and they help maintain that space because you want that space in there. And these are kind of spiderweb-like projections, I guess, if you want to think about it that way. And again, they're going to go all the way around. And the function of these projections is to just help maintain that space between the arachnoid matter and the pia matter. Okay, these projections have a special name. They are called trabeculi. So each of these projections. So I'm just going to label one here. Trabeculae. Okay, trabeculae. Sorry, thank you. There you go, trabeculae. I'm going to give myself some space. Okay, so each of these projections coming out of the arachnoid matter they're called trabeculae. Okay, and the trabeculae are there to help maintain a physical space between the arachnoid matter and the pia matter.
Help maintain space.
Help maintain a physical space. So they help maintain space. They're there to help maintain that space, because that space is going to be filled with stuff. Does anybody know what it's filled with? CSF, yeah. So it's filled with, the space itself is filled, bless you, it's filled with CSF, cerebrospinal fluid. Good. What else is floating around in the CSF there in that space? So one of the things that we talked about last week, remember the cranial arteries? All your cranial arteries are in this is called the subarachnoid space. little about here in a minute. But you're going to have your cranial arteries and your cranial veins. So all of this space is necessary because all those arteries that we talked about and the veins that we're going to talk a little bit about today live in that space. Okay, so all your cranial arteries are floating around in CSF. Okay, and this space right here, so this is the arachnoid matter, but the actual space is called your subarachnoid space. So here's the space. It's called the subarachnoid space. And that makes sense because it's just below the arachnoid matter.
And that's where the CSF.
It's filled with CSF. Subarachnoid space is filled with CSF. And it also houses your cranial nerves and, your cranial arteries and your cranial veins. Questions about that? See how that is? This is so far we talked about 2 different layers of meninges, and there will be 3 total. First is pia mater, that's their soft mother. So named because it's tightly adhered and it provides a nice soft layer of protection to your central nervous system. The next is your arachnoid matter, which has a physical space. The physical space is maintained by something called trabeculae. And the inside that space is called subarachnoid space. It's filled with CSF, has your cranial arteries, and your cranial veins. And that's your spider mother. The last layer, I'll do mine in blue. Okay. Let's start here. So the last layer, there's really no space that's maintained or anything, but there's the last layer here, which I'm choosing to represent in the blue color. Goes all the way around CSF. It's just the next layer after the arachnoid matter. There we go. Okay. Now, we get to here. There's this layer, this meningeal layer, actually goes in to this invagination right here. Okay? So there's an invagination between the cerebral cortex and the cerebellum. Okay? That invagination is known as the transverse fissure. Trans fissure. You're actually going to see it when you pull the brains on Wednesday. This layer of meningeal layer, it's like a plastic almost. It's a very hard material, kind of akin to if you've ever eaten crab and that has that inside skin. Sometimes that's like that hard plasticky stuff. That's what this is like. And this layer of matter, which is known as dura matter, write that down in a minute, is the outermost layer. It goes into the invagination for the transverse fissure, and it also goes into the invagination way up top to this fissure that we talked about that separates the left and right cerebral hemispheres. Does anybody remember what this fissure is called? Longitudinal, good. Okay, so this is the dura matter, goes all the way around, which goes into this longitudinal fissure. Okay, a little about here. I say this because when you try and pull the brain, that layer of dura matter is kind of going to be in your way. I mean, it goes in, and it's a structure that you have to physically remove to pull the cerebellum up with the cortical region. Okay, you're also going to see it up here. This invagination. Well, let's go back and do the dura matter first. So this last layer, which I've shown in blue, is called dura matter. D-U-R-A. Does anybody know what dura means? Yes? Tough. Yes, this is one tough mother. That's your tough molar. Like I said, it's kind of a hard plastic almost, like it's made of collagen. It's dense fibers, connective tissue, but it's a very tough outer coating. Okay, and like I said, it's going to be adherent to the arachnoid matter. It goes in two different places. It follows the transverse fissure that separates the cerebral cortex from the cerebellum. It also invaginates here into the longitudinal fissure, and you're going to see both of those things. There's names for these areas. When the dura matter itself goes into the transverse fissure, okay, there's a special name for it, and I'll label it on this side. It's called your tentorium, Tentorium, cerebelli, Cerebelli. Okay, your tentorium cerebelli. It's kind of like that tent over the cerebellum. It's like a covering. And you'll see it on Wednesday. And when the dura mater invaginates into this longitudinal fissure, it's called your faux, F-A-U-X, cerebri. So two different things, two different structures that are very visible that we'll see on Wednesday. And the tentorium cerebellum and the faux cerebri are just dura mater. Okay. So we're going to pull away the dura mater, and then what's going to be left is the arachnoid matter. And it's kind of cool looking because when you have this layer of arachnoid matter there, you can actually see the arteries and veins underneath the arachnoid matter. So you see them in that physical space. The pia mater, can't really see. It's very tightly adherent, but the arachnoid matter you're going to be able to see as this film over top of the arteries and veins, the CSF. Yes, Tyler?
So, in invagination, you're saying it goes all the way to the pia mater?
It goes into the space, that longitudinal fissure that separates the left and the right halves. And what we're going to do in a minute is I'm going to zoom in and show you exactly what it looks like. Okay? Good question. Any other questions? Yeah, Laura?
That subarachnoid space would be where you would have like brain bleeds and stuff?
Ooh, yeah. One year when we pulled the brains, this woman died of an aneurysm, and you could actually see the blood pooled up inside the subarachnoid space. Yeah, and we're going to talk about that and what it looks like and how that happens here in a minute. So good, you're thinking. We'll get there. That's a hemorrhage. It's a brain pool. Any other questions? Can we see where we are? Make sure we got everything. Okay. Now, one thing that I mentioned here is that L2 is the vertebral level where the physical spinal cord ends. Now, this dura mater and all the other matters go all the way down. Does anyone know what vertebral level it goes to? It goes to this very bottom, where all the dura goes to, is at S2 vertebral level. Where you put that bottom inclinometer when you're doing lumbar flexion extension. S2 vertebral level. That's everything. Okay, is everybody good with that? Move on. All right, bless you. Let's move on to the next one, which is cranial meninges. Okay, now we're going to look at Tyler's question. This is the one that, just the one cranial meninges. Kind of orient you again. This is just a frontal section, and what I've done is I've gone from here. I'm going to zoom in right here to this area right here. Okay, so this is just nothing more than a blow up of that region. Okay, there, see where I am? So just again, this is a frontal section, and this is representative of the skull. You have a bug on you, Ben, or
It's like trees, flowers in his head.
flowers? That's pretty fancy dress for class. Okay, there's my skull, and this is down here. I sort of tried to shade it a little bit, so this is representative of the outer layer of cortex, which we know is the gray matter, right? So this is just physically your brain. And this would be, we'll just keep it the same. This will be the right side of the brain, and then this will be the left side. Now we're going to look at kind of Tyler's question and label things as we go. Okay, let's start with the dura matter. There's one thing that I didn't tell you. There's actually 2 layers to worry about when you're thinking about dura matter. Okay, there's one layer of dura that's very tightly adhered to your skull. Okay, again, this is going to be my blue. Okay, this layer is tightly adhered to your skull, and the dura matter, this layer is called your periosteal. Periosteal. That's your periosteal dura layer. And your periosteal dura layer is very tightly adhered to your skull, and it's particularly tightly adhered to the sutures in your skull. Does everybody know what the sutures are? It's just when the skull forms, when the bones kind of grow together, you're left with those sutures. Your periosteal layer is very tightly adhered not only to the bone itself, but particularly tightly adhered to these sutures in your skull. Okay, so then the dura matter has 2 layers. The second layer of dura matter that we have to be concerned with is known as your meningeal dura. And the meningeal dura is the one that it's going to be, again, fairly tightly adhered to the periosteal dura here. But then it's got an invagination, kind of like a little triangle here. And this invagination, the meningeal dura, goes all the way down. And then that's going to be, this as it comes down is going to be your false cerebri. So all the way around. Let's label that. So the second layer is going to be your meningeal, meningeal dura. Okay, so the dura matter in the brain is just going to be composed of the periosteal dura and the meningeal dura. Okay, and the meningeal dura comes in, and this is the false cerebri. It comes in and goes all the way over. And as you can see, you created a little space in here. This little space actually has a name, and it's going to be lined with little arteries, and then it's got, this is called your superior sagittal, this physical space is called your superior sagittal sinus. Okay, your superior sagittal sinus. Okay. And the purpose of the superior sagittal sinus is going to be to help drain venous circulation and also help drain CSF. And we'll see that here in a minute. But this space is your superior sagittal sinus. And then underneath your dura, you're going to have another layer, and this, again, is your brown, and this is going to be your arachnoid matter. Your subarachnoid matter falls all the way down. All the way around.
What are the dots?
They're little, they're a cell type that just lines the superior sagittal sinus. This is going to be your arachnoid matter. Okay, and coming off your arachnoid matter, you're going to have your trabeculi. Okay, all of those are your trabeculae. Okay, so most tightly adhered to the skull surface is your periosteal layer. Underneath a periosteal dural layer, and then you have your meningeal dural layer just underneath that. Meningeal dural layer, as it comes toward the longitudinal fissure, forms a little invagination. That invagination is a physical space. It's known as the superior sagittal sinus. Underneath your meningeal dural layer, you have your arachnoid matter. Your arachnoid matter has those trabeculae, which are the projections that help maintain the physical space. There's going to be CSF in there as well as your cerebral arteries and veins. Okay, the last layer that we need to draw in there is going to be your pia mater. And your pia mater is just, again, really tightly adhered to the surface of the CNS, and it goes in all the little invaginations. It's not something you're going to see as a layer when you pull the brain, but it's there. It's a soft mother. Okay, and this is your, in green, this is just your pia matter. Okay, that's your soft mother. The way that I've drawn it, there's really no space between the trabeculae and the pia mater. That's just the connection. I mean, they can be upright opposed to each other. Okay, yes?
You said that something goes to the superior sagittal sinus, like venous.
Get there. Yep. There's going to be two things. Venous circulation, I'm going to talk about that in a minute, and also CSF. So in a minute, I'll show you how venous circulation gets there.
Okay.
Okay? Sure. The superior sagittal sinus is lined with it's lined with a special cell type called endothelial cells. That's all. It's just an endothelial cell lining. Okay, but it is a physical space that is between the periosteal layer and the meningeal dura layer. And that's where some stuff's going to drain. Talk about that in a minute. Okay, any other questions? So everybody see where we are? Tyler, does this answer your question now? Can you see? Yeah. Okay. Okay, so come all the way down there. Now, talked about the fact that we have veins in here. I'll make them purple. So we're going to have cerebral arteries. Okay, so here's going to be a cerebral artery in this space. So in your subarachnoid space, it's in your subarachnoid space. Okay, and we also have cerebral veins. Okay, there's going to be your cerebral vein. So this purple thing right here is a cerebral vein. And this superior sagittal sinus goes all the way from front to back. And you'll be able to see it as that triangle when you pull the brain that's kind of tightly adhered. So the way that the venous circulation drains is there's a special kind of vein that comes off the cerebral vein and connects into that superior sagittal sinus. Okay? And these veins are all the way across, okay? So they're going in this direction into the superior sagittal sinus. And these veins are known as bridging veins. They just make a bridge from the cerebral vein to the superior sagittal sinus. Label that here. Those are bridging veins. And they're going to be important when we talk about the subdural hematoma here in a minute. Okay, and I'll even label this guy. So this invagination right here, this is your fall cerebri. In this whole area right here, this is your subarachnoid space. That's the stuff that's filled with CSF, and that's where your cerebral arteries and veins are. Question? Yeah, it's a bridging vein. So it literally makes a bridge from your cerebral vein into your superior sagittal sinus, and that's where your venous circulation drains. Or you have a question? No? Yeah, there.
Does that happen in the transverse vagination as well, or is this only in this?
No, it's only in the superior sagittal sinus. Yep. Mm-hmm. Yep. Okay, and this is something, so you'll be able to see this triangle that's kind of stuck to the skull on Wednesday when you pull it, but realize that there's veins, the bridging veins come from outside and they come in. Okay? Other questions? Everyone see where we are? Okay, so overall we just zoomed right in looking at this cross section. We'll move on. So, moving on to the next one, now we're going to look at different kinds of hematoma, two different kinds that you have to be aware of. And I guarantee you in your clinicals this summer, you're going to be acute care, skilled nursing facility, or home health. You're going to see patients with an epidural or a subdural hematoma, and it's important to know the difference and what that means for clinical presentation. Okay, we're going to look at both of them separately. So this, let's just draw kind of a dotted line between the two. And on this side, on the leftmost side of the page, I'm going to draw the epidural hematoma. And on the right side of the page here in a minute, we're going to look at the subdural hematoma. Okay, let's start out here. Okay, looking at this is a standard frontal cross-section, like we saw before. So this is going to represent your skull. So thinking about the word epidural hematoma, where do you think the blood's going to pool at? Above. Yeah, it's going to be above the dura mater. Okay, so it's epidural. All right, let's look at the dura mater. So remember we had a couple layers of dura mater, and I'm going to represent the I'm going to represent the problem on the leftmost side of the skull. So let's start on the rightmost side of the skull where things are going to look kind of normal. So remember, what's the layer of dura mater that's tightly adhered to the skull? What's the name of that? Great, periosteal layer. Okay, and that periosteal layer is going to be tightly adhered to the base, to the skull, underneath side of the skull, and it's also going to very tightly adhere to these sutures, pretty much. All right. Okay, so we're tightly adhered, and we're going to get to here, okay, and the cause of the epidural hematoma is going to be trauma. And think, hit to the head. Okay, somebody gets hit in the head. So you have a fall, and you hit your head, and you could possibly cause an epidural hematoma. So in this case, the hit to the head happened over here. And what's going to happen is blood is going to start to pool above the periosteal dura. Let's label that. This is your periosteal dura. Okay, so signs and symptoms of somebody with an epidural hematoma. Okay, this is just trauma. Get hit in the head with whatever. Blood starts to pool. No, the trauma is a hit to the head, and the problem is that the meningeal arteries rupture. So between the skull and the periosteal dura, you have these things called meningeal arteries. When you get hit in the head, meningeal arteries can rupture. When the arteries rupture, then you get a pooling of blood underneath the periosteal dura. Okay, sorry?
How is it between two sutures, or is that just?
Yes, good question. So it's characteristically in between two sutures. So the way I've drawn it up here, it sort of looks like half a tennis ball. You're going to see that picture. So if you looked at does anybody know what kind of imaging that you'd see this with? CT scan, yeah. CT scan is going to be really good at picking up blood. Okay, you're going to see the change in the shape. You're actually going to see it on a CT scan. If you're looking at an epidural hematoma, it's going to look like a small piece right there, just like that. That's characteristic for an epidural hematoma. Okay, patient signs and symptoms. The patient might have a headache, maybe, but pretty much they're going to hit their head and say they feel fine. You know, they can go for days, sometimes a week, and be perfectly normal. Okay, they might have a little bit of a headache, they might not, it depends. But then, in that time when they're feeling normal, is called a lucid interval. LUCIDINTERVAL, a lucid interval. Okay, that lucid interval is that time after they hit their head, and they're perfectly okay. They're not really demonstrating any signs and symptoms, maybe a mild headache from where they hit, but nothing much more than that. And then all of a sudden they become unresponsive and go into a coma. Okay, it just takes a lot of time for the meningeal artery blood to pool, and the more blood that's pooled there, the more pressure you're going to put on the brain. We'll draw the other layers. Okay, so after the lucid interval is over, then they become non-responsive and go into a coma. Okay, so family might say, well, they hit their head about a week ago and then they seem just fine, but now, we can't wake him up or her up. Does that make sense? You have that period of time that's known as your lucid interval. That's very characteristic for an epidural hematoma. And the treatment, so what they do is bring the person in, do a CT scan, you see this visual area between the sutures that's filled with blood, and they do something, they drill something called burr holes, B-U-R-R holes, burr holes. That's literally, the surgeon does a small, teeny tiny small incision. Okay, they shave the head, small incision, and then they literally take a drill through the skull and evacuate the blood, release the pressure and evacuate the blood. Okay, as far as working with a patient that has burr holes, the only thing you're going to see is they're going to have a shaved spot in their head. You're going to see a couple little sutures, but that's it. They don't do anything about the hole that's there. It's not something you really have to worry about if somebody has burr holes drilled in their head. You really don't see them. Okay. Has anybody seen anyone with burr holes? Yeah, go ahead.
I have a question. When, after the burr holes are inserted, somebody who's unresponsive or in a coma, how long after the blood has been drained do they become responsive again?
It's going to depend. I'll show you. Well, we're going to draw the rest of it now. And it will depend. It depends on patients with hematomas and also hemorrhages tend to fare much better than patients with ischemic strokes. Okay, so once that blood is evacuated, as long as the brain hasn't shifted too far, called midline shift, then that person should be okay. They might not be quite right yet, but they'll be doing okay. And it's going to depend on how much is filled up in there. Any other questions? So you got these burr holes. What was I going to say? Oh yeah, let's go ahead and draw in the rest of this so you get a better picture of what it looks like. Where's my, yeah. So underneath you're going to have underneath your periosteal dura, you're going to have your meningeal dura, right? And that meningeal dura has this little invagination here. It goes down like that. And then under, that's your meningeal dura. Okay, underneath your meningeal dura, you have your arachnoid matter. And your arachnoid matter looks pretty normal on the right side, but on the left side it's fairly misshapen. You have your trabeculae that are sticking out all over. Okay, and then you have your pia mater. So your pia mater is tightly adhered to your brain. So it's going to look pretty normal over on this side. You're going to have it going into all your invaginations, right? And then kind of a nice, normal-looking brain presentation. But on this side, it's going to be severely misshapen, right? So it depends on how much pressure is put into by the bleed, how much blood is actually pooled there, as far as how much pressure is going to be put on the brain. And that's your epidural hematoma presentation. Epidural hematoma, just direct trauma, blunt trauma to the head. Most commonly seen in the temporal region because that's where the bone of the skull is the thinnest. Okay, right over here in the temporal region. You may have a skull fracture that goes with it, maybe not. Might be a hairline fracture or something. Patient's going to have maybe complain of a headache, be perfectly normal for a little while, and then that's called your lucid interval, and then they're going to be non-responsive. Okay, take them to the ER, and then they drill in some burr holes right in here and evacuate the blood. Okay. Yes, Jared?
So the main application of normal physical therapy is just understanding that if they hit their head, ask further follow-up questions before you're supposed to refer them.
You'll know. So you'll have it. You'll have a patient history in front of you, depending on what setting that you're in, and they'll probably say that there's an epidural hematoma. You might be able to look at the CT and see something like that, but you should expect when talking to this patient and or their family members that they hit their head and then there was this time they were perfectly okay, and then all of a sudden. The other thing to remember from physical therapy presentation is that when you have a patient with burr holes, you don't have to do anything special. Okay, that's going to be different than your subdural hematoma. We'll talk about that here in a minute. Okay, any other questions? Okay, so then moving on. So this is your epidural hematoma. Now, if you look over here, let's see if we can look at a subdural hematoma. kind of the same thing. This is your skull. So your standard cross section. And then you've got your sutures. Now, question? No? Question? No? Okay. Your skull with your sutures, just like before. And we talked about the first layer, tightly adhered to the skull, is going to be your periosteal layer. And since this is subdural, I'm not really going to see a change there. It's going to look pretty much like normal. Okay. Now we've got your periosteal dura. Okay. And then kind of the standard presentation for your meningeal dura. I'm going to come all the way across. Okay. Little invagination. False cerebri coming down. Okay, we've got our two dura layers there. We've got this little superior sagittal sinus there, and catch up. Okay, so it's subdural. So now the problem is going to be below the level of the dura mater. Okay, so what I'm going to do on this side is I'm going to choose to represent the problem on this side, on the right-hand side of the figure. On the left-hand side of the figure, I'm just going to go ahead and draw in what's normal, or what you'd expect. Right, you have your arachnoid matter, next layer, and then you have your trabeculae coming off of that. We've seen that before. We talked about that as the subarachnoid space, and the subarachnoid space, I said, has some cerebral veins here, and these cerebral veins are connected to the superior sagittal sinus by these bridging veins. So here we have cerebral vein, okay, and it's connected to the superior sagittal sinus by this bridging vein. Okay, nothing new there. Everything pretty much the same that we just saw. See where we are? Okay, and then if we had to go ahead and draw, on this side we're going to look normal, so here's your pia mater. So all the different invaginations, pia mater is going to be pretty much like normal, tightly adhered to your brain. So here's your pia mater. Here's your arachnoid. Pia mater, arachnoid mater, and your dura mater. 2 layers of dura mater. Okay, let's take a 10-minute break.